we're going to present a case, a very complicated case of a rotator cuff patient who has restriction and tear. So this is a patient who is 77 years old. He has had, this case was a patient that I saw in 2012, so almost 10 years ago. And so at the time, he had an MRI that was done in 2005. So many years, 7 years before he saw me. And but since then, so he's been suffering with this rotator cuff problem for at least 7 years by the time he saw me. And so it's very unfortunate. He has subacromial bursa that I mentioned. Okay, so that subacromial technique is where that becomes very handy. He has a 1.4 to 4 centimeter tear in his supraspinatus tendon. And then there's also ossific fragments in the subcoracoid recess. The report summary was that there's tendinopathy of the supraspinatus and the infraspinatus muscles. Okay? So upon initial assessment, this is what he can or cannot do. With his right shoulder, this pain started in 2005. He's unable to external rotate the shoulder. There's no pain, but he just is weak. He cannot external rotate. This restricted internal rotation with pain, so his subscapularis cannot do his job. The abduction is only 30 degrees. Okay? And then there's a palpable pain in the supraspinatus muscle. The flexion of the shoulder, it was only 45 degrees and is restricted by pain. The left shoulder is not as complicated as the right one, but it still has this limitation of the flexion at only 45 degrees, whereas normal people should be able to do 180 degrees, right? So, and by palpation finding, we found action points or trigger points in some of the areas that correspond to the supraspinatus, such as small intestine 12 and 13, infraspinatus, small intestine 11, and then long two areas, this would be more in line with the bicep tendon and also pec major and so forth. So my general impression was that this person's inability to external rotate was due to an inhibition of the infraspinatus and the teres minor. Those are muscles that does that job, and these are the nerves that would be responsible for those muscle activation. The pain on internal rotation was possibly due to a subscapularis involvement. The right supraspinatus tendon tear, based on MRI, shows the limited range of movement, abduction of 34 degrees. And this is confirmed by there's also trigger points in the supraspinatus muscle itself. So small intestine 12, small intestine 13 area. The bilateral anterior shoulder pain with 45-degree flexion. So there's pain in the anterior shoulder, and there's only limitation of 45-degree flexion of the shoulder. And so the pain in the left shoulder developed 4 years afterwards. So it's likely due to compensation because the right side is not working. So he's now forced to use his left hand, and then that more, and then left hand now starts to develop problem sometime down the road. And so understanding that the flexion of the shoulder involves muscles such as anterior deltoid, coracobrachialis, and bicep tendon starts to help us hone into what are the possible troublemakers that this patient is responsible for this patient's symptomology. So the initial treatment plan is that I want to activate the teres minor and infraspinatus to restore the external rotation. I want to reduce pain that we found with limited internal rotation. I want to promote healing of the tear in the supraspinatus tendon, and in so doing, increase this range of movement, which is abduction. And I want to reduce the bilateral anterior shoulder pain and increase the flexion from 45 degrees to however much degrees I'm able to get out of this patient. The recommendation is to do 2 treatments a week for 4 weeks, which means 8 treatments in total, and we will reevaluate after this 8 sessions. So these are each of the 4 objectives of my goals. To activate the teres minor infraspinatus muscle, we needed to activate the nerve supply. So fortunately, this teres minor is over here. The nerve to the teres minor, which happens to be called the axillary nerve. We don't have to go into that too much in detail, but there's a branch from the axillary nerve that goes into the teres minor, and it happens to be a traditional acupuncture point. It's called Jian Ho. So in fact, it's actually a motor point. And then we already mentioned that small intestine 11-C, the casca point, was the nerve to the infraspinatus. So collectively, those 2 points or slash nerves, I use them interchangeably, will be able to activate these 2 muscles to improve and restore the external rotation. As far as reducing pain on internal rotation, we need to target the subscapularis muscle. And the way I do it is similar to the video I showed you, where I used the pointer pulse device as a treatment itself. The pointer pulse device is that little pen you saw in the video, which I was used to stimulate the needle. I use that device, which is a 10 Hertz device, to give it 30-second stimulation with 3 repetitions. And that's the type of treatment that I mentioned. We take the needle out, immediately retest the patient, and 8 times out of 10, the subscapularis will immediately strengthen on the spot. And because the subscapularis attaches to the anterior aspect of the humeral head, for some reason, by activating it, 50% of the time, the pain will be reduced as well. When it comes to promoting healing, objective number 3, promoting the healing of the supraspinatus tendon on the right, what we want to do is we want to put needles, okay, at the AC joint over here. So I demonstrated how we put 2 needles in large intestine 16. I demonstrated as kind of acromial needling technique. Collectively, when you fly electricity between them, you're going to send current into not just the joint capsule, but into the subacromial space. And that's going to help with the bursa that this patient has. And also this, by increasing blood supply to the electricity to this tendon area, we increase blood flow and oxygenation, so that we can try to improve the blood supply to these tendons as much as possible, with the preface knowing that tendons are notorious for having very poor blood supply to begin with. But fortunately, the clinical results have been very reproducible with this technique. And so even patients that come to you with teres, with bursas, we've been able to actually restore them. So I hope that gives you a little bit of confidence that just because it's torn doesn't mean it's something that is purely a surgical intervention. Acupuncture can actually do quite a bit to help repair these tears. Now, to reduce the bilateral anterior shoulder pain, increase the flexion range, we needed to target the muscles of flexion, but we need to also be aware there are many muscles that actually refer pain to the anterior shoulder. For example, you're looking at trigger point of the infraspinatus muscle, yet it can refer pain to the anterior shoulder, even sometimes down the arm. I'm showing you this picture over here of the biceps, just to remind everybody that the bicep has tendons that run across the anterior shoulder. So even a bicep problem can oftentimes feel like an anterior shoulder problem. So you could be wasting all your time treating the sits muscles for anterior shoulder pain, but it actually ends up being a bicep problem. So this is why you need to be somewhat familiar with your orthopedic testing to do a test for the biceps, to just quickly eliminate the possibility that the patient comes in with a rotator cuff syndrome, which is predominantly pain in the anterior shoulder, is actually due to rotator cuff and not due to bicep, for example. Okay, so I'm going to skip over some of these innervation, and so I'll get right to the treatment outcomes. So the immediate treatment outcome, immediately after the first treatment, so the patient hasn't even gone home yet, the external rotation of the shoulder has restored. It wasn't painful to begin with, it was just weak, but simply by activating it, improving electrical flow to the muscle, it made the muscle, patient able to activate the muscle. There is now cessation of supraspinatus muscle pain that was previously elicited by palpation. So that palpating the trigger point has come down, the amount of pain. So the next treatment, what we're going to do is we're going to focus on the abduction of the right shoulder to try to promote healing of the supraspinatus tendon. And then want to work on the anterior, bilateral anterior shoulder pain. So, but before I treated the second treatment, I reassessed the patient and have found that the previous pain on the internal rotation of the shoulder is actually alleviated, and the anterior shoulder pain, now we know, it's not just there when he's moving, but it's there when it's at rest as well. So this makes me suspect that it could actually be the bicep tendons that I just mentioned to you earlier, because if you're not even using your arm, therefore you're not even using your sits muscles, your rotator cuff muscles, yet you have anterior shoulder pain problems. Obviously, it's not the rotator cuff muscles that are responsible for it. Right? So it's got to be something else. So we repeat the same exact treatment, okay? But this time we added treatment for the long bicep tendon, and we're using electricity, something called row needling. It's Chinese called 排刺, just be 3 or 4 needles along the bicep muscle and tendon junction area with Easton for 10 minutes. And also address the brachial plexus nerve roots, which, as you know, brachial plexus C5 and T1, by targeting Huatujiaqis of those relevant C5 T1 levels. And the reason for doing that is because this is an elderly gentleman who is very obese and has that kind of forward neck carriage posture. So chances are there is something messed up with his cervical spine. And just in case that some of the symptomology of his upper extremities actually has a radicular issue, underlying component, I might as well just try to improve the nerve flow from the root level, and it'll save me some time than just sort of only treating things locally. So before the third treatment, reassessed. Now, the right shoulder is able to abduct 90 degrees, which I remind you used to be only 30 to 40 degrees when he came to see me. Not only that, he says that there's only tightness now. He doesn't experience that as a type of pain anymore. The patient notes that however, even though it's not painful, the patient is able to identify that there's kind of tightness, pulling feeling, and the patient actually pointed to the small intestine 12 area. So that's great, because the patient telling you what you need to do. Basically, you need to go needle supraspinatus muscle, continue to needle supraspinatus muscle further so that you can loosen it, so that's not going to give you this tightness, pullness feeling. One thing that I teach to students is that the reason why tendons tear is actually because the muscles are short, and the muscles that are short will then tug on the myotendinous junction and cause the tear to happen. So we actually, if we can just increase the length of that muscle by relaxing it, by getting a local twitch response, the ends that are micro tearing are now going to have less forces pulling on it. Those ends are naturally going to be able to heal. That's what our body does. We can heal. But it's just always being undone by continuous re-shortening and re-tearing, basically. As long as you can allow the healing to happen faster than the shortening, then the patients are going to see results and you can be able to move forward. So this is why it's also important to teach patients some stretching techniques for these rotator cuff muscles, so that you can help them lengthen these muscles as quickly as possible. And then there's no improvement on the right anterior shoulder flexion and pain. So this is still under investigation. And so for the 4th and 5th treatment, before the treatment, I reassessed them. This time the abduction that was increased 90 degrees kind of dropped a little bit to 75. Not sure why, maybe just not enough treatment, not enough dosage. But the left shoulder flexion with pain and the right shoulder flexion with pain that was previously only at 45 degrees is now at 90 and 60 degrees. Okay, and then so the treatments are pretty similar. And before the 5th treatment, I reassessed again. The right shoulder abduction now returned to 90 degrees now. The Ashley points we found Ashley points in the anterior deltoid and coracobrachialis. So that's might be the reason why I'm not able to get this any better than 90 and 60 degrees, because those muscles are involved in flexion. So we also treated the Ashley point in those area. Some distal point ideas are always welcomed. Points such as LI4, which is part of the same channel. Stomach 38 is related to frozen shoulder. So if you're going to use the distal point, you might as well use the distal point that has some channel senior relationships. So we incorporate that as well. And now by having treated 5 times so far, the right shoulder is now able to abduct to 130 degrees now. Previously, it was actually, last visit was 90 degrees. When they came to see us, it was 30 to 40 degrees only. Okay, and then the patient pointed to the left supraspinatus muscle as tender. So this is a good sign. Patient was originally complaining about the right shoulder. They're pointing to the right supraspinatus, but now it's not bothering them anymore. Now they're pointing to the other side, having a problem. So the patient said, by the way, can you also fix my knee? By the way, can you also fix my other shoulder? That means the original problem they came to see you for is actually not even in the forefront of their mind anymore. Okay? So it's not that this pain moved. The pain was there the whole time. It's just that the pain on the right side was more pronounced to their brain. And until it came down, then they were able to notice a lesser secondary pain. Now, what is become perplexing is that the left anterior shoulder pain was not improving. And the one, especially the one that's at rest. So I'm missing something here. So I went in to palpate the short head of the bicep. Remember I showed you that picture, the tendons of the bicep actually cross the anterior shoulder. And I found there's just this quarter size gummy area and in the tendon. So that clued me that I should better do an orthopedic test of the bicep tendon. The name of the test is called Speeds test, as in high speeds test. And that test, sure enough, showed a positive sign. So the person's anterior shoulder pain, in addition to rotator cuff syndrome, actually had a bicep component. So had I not done that test, I would have just continued to treat the rotator cuff, and I would have plateaued because by not knowing the anatomy and thinking that it's a rotator cuff syndrome, by over-relying on the MRI result that showed tendinopathy of rotator cuff muscles, I would have completely missed other structures. This is why a good clinician should not over-rely on diagnostic imaging. You must also combine it with clinical findings and also with palpation and also with neuroorthopedic assessments. Okay, so just to wrap up for the rotator cuff syndrome, the pain was always on the right side for supraspinatus, and then it got better. They complained about left side supraspinatus, so we treated left side supraspinatus. Now the left side supraspinatus pain is also gone. Right shoulder abduction is holding 130. We're not getting any better. The patient probably needs to do a lot more stretching and continue to do the acupuncture to actually reach, 170, 100, maybe not 180 degrees, but definitely at least 150 degrees. It should be achievable. The left anterior shoulder pain at rest is now improved by 50%. Now, by having addressed those gummy things in the bicep tendon, the left shoulder is able to, and the right shoulder can now flex 90, 120 degrees now. Okay, so unfortunately, this patient was never able to finish all 8 course of treatments. And these things happen because when people get better, they just stop coming. And but nevertheless, I wanted to show you how a very complex, super complex case that wasn't even just supraspinatus, that wasn't just even the rotator cuff issue, combined with bicep tendinopathy issue and the undeniable tears, can achieve very life-changing improvements for this elderly gentleman whose healing ability was expected to be very unimpressive to begin with. Okay.